welcome to Savage Minds. I'm your host, Julian Vigo, and we have a very special guest today. Dr. William Malone, a board-certified endocrinologist. He's a graduate of Stanford University and New York University Medical School. He completed a residency in internal medicine and a fellowship in endocrinology, diabetes, and metabolism at Los Angeles County University of Southern California Medical Center. He's been in clinical practice since 2008 and holds an appointment as an assistant clinical professor of endocrinology from the Idaho College of Osteopathic Medicine. Welcome to Savage Minds. I first read about your work, both between your Twitter feed, your Quillette piece that you co-authored with Colin Wright and Julia Robertson, and then other places that you've had an input into this debate. How did you learn about the dangers inherent in the medical and hormonal treatment of transgender people? I mean, how did you come into this?
Sure. So I think a couple things happened at the same time, and this was 2017. So about 3.5 years ago, two things happened simultaneously. One was at the Endocrine Society international meeting, which is attended by thousands of endocrinologists and primary care doctors and others. At that meeting, the Endocrine Society essentially presented a set of guidelines for adolescents and children with gender dysphoria. And at that presentation, there was a radical shift from the previous set of guidelines that had been many years before. And, as I sat in the audience there and was listening, basically the guidelines were pro-affirmation. So, the message to us from the presenters, the writers of the guidelines, they'll get up and present their guidelines in front of, this massive audience. The message was essentially, your job as an endocrinologist now is to affirm medically, adolescents who have gender dysphoria and are requesting medical therapy. And those that essentially means giving puberty blockers and cross-sex hormones. So for a woman, it would be testosterone, for a female, testosterone, for a male, estrogen, and others. And that cascade of hormonal treatments, if initiated at the early stage that the guidelines and the guideline authors were recommending, results in likely permanent infertility, sterility, essentially. And so that was, that's a dramatic intervention. If you intervene medically in a young person's life and they are essentially sterilized as a consequence of that intervention, that seemed like a big deal. And I've said this before talking to other folks. I said, well, there must have been a titanic shift in the literature. There must have been a study that I missed, or some advancement to justify such a dramatic intervention. And unfortunately, when I started to look at the sources and the data that was referenced in the guidelines, that data did not exist. There was not good justification for those interventions. So that was alarming. And this was, this started to occur right about the same time that I started getting phone calls from primary care doctors, basically saying, "Hey, we're seeing this new phenomenon of primarily young, right around the time of puberty or just after puberty, adolescent females who are declaring themselves as transgender or non-binary. It's occurring in groups of young girls." So one member of a a friend group will declare a transgender identification, and then others will follow. These, the primary docs were telling me, these, their patients, many of them had histories of trauma as children, or, were struggling with the emergence of same-sex attraction, things like this. And so those two things started to happen at the same time. And then, I had some limited exposure to this area of endocrinology through training and earlier career, which I can discuss. There was basically an original framework for thinking about transgenderism that was based on biological reality, and it was kind of a niche focus. But I can go into that a little bit better. But the main thing that occurred is in 2017, and this had been happening, prior to me seeing it first person. But a dramatic shift, essentially, from the old paradigm of understanding what would cause an individual to declare a transgender identification and then pursue medical and surgical interventions.
I do know that the history of this medicine is highly contestable. There are studies that show that even not just children, but amongst adults, the benefits of cross-sex hormones are not definitive. I mean, I'm not seeing literature that proves that this is actually helping. And I do wonder, aside from the issue of particularly children, although there are logical issues why we would be concerned about children that can't grant consent, that are making life-changing, even disabling decisions from the ages of 14 or something. But if you go back to the mid-20th century with the emergence of this kind of, I'll even call it, again, no offense to people in this profession, but it comes off to me as a bit of quackery, in the sense of when you look at what John Money did and what was happening around the gender clinic that eventually formed at Johns Hopkins, then the dissolution of that clinic in 79, the quick formation of WPATH on the heels of that. This has all the markings of a lobby group more than an actual peer-reviewed, scientifically based mission, let's say. What can you say to our listeners about how the result of I have gender dysphoria, or as you wrote in one article, you're not born in the wrong body, but that was the myth. I was born in the wrong body. All of these kinds of cries for help both reek of either mental health issues and or sort of tropes from the medieval period, if you know what I'm talking about. This is what the Catholic Church was invested in at one point, like trying to cure the spirit through the quote unquote torture of the body, if I might put it that way. And I'm just wondering, how is it that medicine, quickly after World War II, especially in North America, got invested in curing what might have appeared to doctors to be a man not at home in his skin, because these were mostly male patients at the time, cross-dressers or repressed homosexuals, as was often diagnosed, right?
Yes. Yeah, that was the original framework, essentially, for mostly men who were seeking transition. Either they had autogonophilia, so they're heterosexual men who were sexually aroused by the thought of themselves as women. This has been described by Ray Blanchard in some detail, or as you mentioned, men who were same-sex attracted, and essentially, traditionally they came from backgrounds where that was not accepted, and so they were felt rejected and ostracized, essentially. And so that was the original framework for why an individual, why men would seek to transition. So, you're right there. When you look at the long-term studies on folks who have had these interventions, study after study and, systematic reviews of studies have really failed to show any benefit from these interventions. Now, there are folks who will say that these interventions have helped them, but when you objectively look at the data, you can't actually show that. You can't actually prove that. And I think that's, one of the most alarming things, from my standpoint, is that the lingo and the language and the guidelines coming out of the medical societies is in stark contrast. So it's very, pro-affirmation and, really almost uncurious about why somebody would declare themselves to be the opposite sex. Really, dismissive of psychotherapy. So the language coming out of the medical professionals and the medical societies does not reflect the underlying reality of the studies that have been done in this area, basically showing, failing to show especially long-term benefit. And that's really been one of the things that motivated me to start speaking up was it doesn't seem right. It's not right to give a patient an expectation or to essentially give them a false hope or to misrepresent the validity of the data if they're contemplating these interventions. Physicians are supposed to do the opposite. We're supposed to be, objective analyzers of the literature, and then, package that information up into a digestible bits that patients can, use to help them make decisions. And certainly in this area, it's that's not occurring, and it's in stark contrast to how other discussions occur with patients and how information is transmitted and analyzed. And it's been very distressing. And there are many physicians and researchers who feel the same way. And I've had the good fortune to be working with a number of them through an organization called the Society for Evidence-Based Gender Medicine. Essentially, that's our point, is that the rhetoric is far is really divorced from the reality of the data here, and it's a disservice to individuals with gender dysphoria to tell them, these interventions are going to relieve your dysphoria, and this is the only path that it's settled science, and this is the only path that you should go down. And that's really a misrepresentation of reality.
What does the data say about those who go on to take cross-sex hormones? And what would the difference be between, let's say, a survey of people who identify as transgender and getting their quote unquote satisfaction survey, and
Right.
what a scientific survey would in fact differently read?
Yeah. That's a great point. And I think it really gets to the heart of the issue. So if you subjectively ask an individual, are you satisfied with the treatments you've received, et cetera, versus, so that would be a subjective questionnaire versus objective markers of psychological health. So utilization of psychological medications, anti-anxiety drugs, antidepressants, hospitalizations for suicide attempt, things like this. And I think that gets really to the heart of the matter is when you look at objective data, and this has been done. For example, it was done in 2016 by by CMS, the Centers for Medicare and Medicaid, and they looked at many dozen studies and found them to be very poor quality in their design. Most of them where good information essentially could not be obtained. And then the studies that were done decently, there was no benefit shown. And this has repeated itself essentially over and over again. There was a long-term or a population-based study out of Sweden. There are two now, looking at long-term effects of one of surgery and then the other of hormones in surgery. And these studies, the first study showed rates of suicide are still elevated after transitions years later. And then the most recent analysis initially claimed that surgical interventions reduced markers of mental health status. So essentially, less hospitalizations, fewer hospitalizations, fewer utilizations of antipsychotic drugs and antidepressants, et cetera. But that study was reanalyzed and showed no benefit. They actually had to correct the study and report the truth, which was, okay, this analysis again failed to show any benefit from these interventions. So the objective data is basically failing to show long-term intervention. But that information, in my opinion, is not reflected in the guidelines, and certainly it appears not to be being delivered to individuals with gender dysphoria based on many reports of, for example, detransitioners coming back and saying, no, I was never counseled and told the truth about the data. I was told affirmation was the way to relieve my gender dysphoria. I was offered little or no counseling, and down the intervention pathway I went.
It seems to be the case with many people I've spoken with who have gone through these various forms of transition from hormonal to surgical, that even though at the time, even if they had been informed, they were like very young. Some of them were even minors, making decisions that, if I have to think of some of the stupid decisions I even made in my 20s, heaven forbid I'm held to that. And we also know that the human brain, depending on what studies you rely upon, but the human brain isn't really fully formed until anywhere, I've read, between 27 and 29. So how is it possible that we're giving carte blanche to extremely young and impressionable people who, as you noted, when one person in their peer group transitions, it's often a domino effect. We've seen this even in Brighton. When you talk to kids there, they will talk about all their friends who have either identified as non-binary in a non-medical way to many other friends who have begun medical transition. And it seems to me that the science isn't being followed carefully enough by sociological, even anthropological studies that are able to account for this rise. Because as I put it, I say to, some people, well, look, this is the only kind of medical pathology that has been so politicized. There's a few others, by the way. Chronic Lyme disease, chronic fatigue syndrome. I've gotten death threats for writing on those articles on those subjects. But this is politicized to such a degree that we are told how to speak about these individuals. Doctors are told to include the DSM, changing the language, the last two editions, from it being a medical pathology to, not a disorder. Now it's just a condition. So we're going, light on what are serious issues, because no judgment, so many of us suffer from various emotional and mental health issues. But why is there this conterminous push? And it's a paradox, especially in a country like the US, where we have private health insurance still, that people want it medicalized so they can have it covered in countries like the UK or Australia, but they want it not declared a mental illness at the same time, so that there's no stigma. And at the same time, this necessarily affects treatment, because in countries like the UK, I was, raised in the United States and did my graduate work in New York, where if you're not talking about your therapist at a party in someone's kitchen, you don't live in New York. I'm making a joke there, but therapy is highly embraced, a bit fetishized in New York, where in the UK, if you suggest therapy, even to a friend who's going through a breakup or something, the response will invariably be, I'm not crazy. So you have, on the one hand, a stigma about mental health issues within this lobby. And on the other hand, you do have people with genuine gender dysphoria, as you point out, who are not being steered toward perhaps better interventions. And I would argue, having read so much data on this, that the talk therapy should be stops 1 through 10 on the roadmap before making serious changes in the body, not just for the reasons of which you mentioned, in terms of this doesn't necessarily work to lessen suicide and self-harm, but there's a whole other layer about what cross-sex hormones do to the body. For instance, hormone replacement therapy for women undergoing menopause. We know about dangers with that. And I had written a piece for Quillette about the dangers of, well, the trans in sports issue, but I also found out while I was interviewing one of the doctors doing work on this subject for the Olympic Committee. He said the lessons that were learned with hormone replacement with women had to be relearned. And he pointed out to the Coronary Drug Project in the 1970s, where men were given estrogen to lower the risk of cardiovascular disease. And these trials were shut down because people were dying at the rate of, out of 8,341 patients in that project, at least 2,333 were known to have died by the end of the trial in February 1975, which is a really high number. And so one can only wonder, even if you want to call yourself, let's say, a trans ally, to everyone's free to make their choices. Okay, let's run with that ball. Why are the negative effects and extremely harmful effects, because these numbers from the coronary drug trial are extremely alarming. I mean, these are deaths in the order of over 25%. So why is that not being discussed publicly, even in the media, of which I'm a part? You see cheerleading going on. You don't see people or interviews with doctors who are actually chiming on about the positive and the negative results, right? We're never hearing about the deaths that happened because of trans-identified females who have taken testosterone for 20 years and what that does to their bodies.
Yeah, you bring up many good points. So, as you mentioned, so women who take testosterone, they develop heart disease at a much higher rate than the general population, significantly higher. It's 4 to 5 times the odds, essentially. Men who take estrogen develop strokes and blood clots at roughly 3 times baseline. So there's significant cardiovascular risk, and so I think to try to answer why these things aren't being discussed, and the other just known. So that's something that's been known forever. So for example, if an endocrinologist, if a patient, if a woman comes into an endocrinologist's office and he or she, the endocrinologist diagnoses that patient, that woman, with a testosterone secreting tumor, it's almost an emergency to try to find that tumor. They're usually located in the ovaries, to find that tumor and to remove it because of the negative impact on the heart. The risk of heart disease is so high that it's almost a panic when an endocrinologist discovers a testosterone secreting tumor. So this is, as you've said, this is already known. This isn't new. Yet it's been buried and now being rediscovered, quote unquote. And the second that is just known in all of medicine is that the human brain is not fully mature and formed until the mid-20s. And, it was just part of training. I can't tell you the number of times that, this was reiterated is, for example, when I went through training, many gynecologists would never do a hysterectomy on a woman before the age of 25, unless there was a life-threatening reason and it needed to be done before the age of 25, because of this understanding that if the woman said no, I'm done having kids, or I don't want children, that her mind may change between the age of 20 and 25, and then if you intervene before that age of brain maturation, you may have made a mistake and denied that patient something that she would have wanted, and would have made a different decision if she had waited a little bit longer. So this brain maturation thing is also something that is well known in medicine and all other fields of medicine in terms of consent and making big decisions. And so the a couple big names in the field. So folks who were advocating for psychotherapy for folks, or some form of psychological intervention, counseling for folks, young people with gender dysphoria, were fired. So Ken Zucker in Canada, and there was a doc in the U.S. He was the head of the Department of Psychiatry. I forget his name, in one of the southern states here, and he was on a panel and said, no, this is an identity disorder. Nothing's changed, despite the language change, and counseling, psychotherapy should be first line intervention. And he essentially, his contract with his hospital was, he was essentially fired as well. And it doesn't take many examples of that to send a chill through the entire medical field. So a couple stories like that show up in the newspaper, and immediately everybody goes silent. So that's the politicization of this has a really chilling effect on dialogue. And in addition, I think there's one other thing that occurred, and it's hard for me to pinpoint exactly when this happened. I think this was it was between the most recent version of DSM and the previous. And so what occurred as the most recent version of DSM was being put together, patient advocacy was becoming a thing, let's say. And the way I describe this is basically patients were, and I'm not opposed to this, but patients were invited with gender dysphoria who were transgender identified, were invited into those conversations. And so essentially, at WPATH, for example, patients were invited to give their opinion. And like I said, I support that. I don't have an issue with that at all. But that lobbying effort had, in my opinion, an impact on the guidelines and also the DSM criteria that came out, that was not based on the scientific data. So essentially, that influence really has altered the language and the the discussion that's quote unquote even allowed to occur in this area. And I think that's not being discussed enough either. So like I said, I think it's great to get input from groups who are invested and directly impacted by guidelines and by diagnostic criteria. But the physicians and the researchers with their training and experience are supposed to take that information, but then, generate criteria that are still based on the scientific data, and that's not happened. So, the guidelines, in my opinion, are more reflective of the lobby interests versus the actual scientific data.
Well, that's very clear when you go on social media around the change of the DSM-4 to 5, when it was called back then, not so many years ago, let's say 5 years ago, it was gender identity disorder. And the lobby pushed to have the disorder removed and even the terms of gender identity. So now it's called gender dysphoria. But here's the thing. As someone who, I've written about this now for many years, and I found it really shocking to have people tell me that I am cis. Because as a woman, and men deal with this too, boys deal with this too, to different degrees, and mostly smaller degrees, I'd argue, in certain ways. In other ways, maybe vestiture, they have to struggle more. But because I can wear anything I want and I will never be trolled on the street and, made fun of. But one thing that really struck me is that I was constantly having to tell people in real life and social media, but I don't have a gender identity. See, this is the myth that's been peddled by this lobby that I think is the nut inside of this entire problematic, if I can call it that, because the assumption is an unprovable God, let's say. We are told that we all have a gender identity. And if you're wearing a tie, you're conforming. If you're wearing I don't know, something out of Barbarella, what Jane Fonda wore in Barbarella, you're not. And so this is a bit absurd to me. I'm a scholar. I've done work in comparative cultural studies and anthropology, and I know that gender is completely social, and I don't even think this. We have evidence of this. This is why if you go to Morocco, you go and you wear a djellaba or a kaftan, and the djellabas for women are cut quite differently than the djellabas for men. The same thing happens with male and female styled clothing in the same Muslim world, but on the other side of North Africa and Egypt. And gender is extremely performative and extremely linked to vestiture in every single culture in the world. People fell in love with In the Mood for Love, 10 years ago with Maggie Cheung matching the wallpaper, or, 50 years before that, The Umbrellas of Cherbourg with Catherine Deneuve matching the wallpaper in that movie. But these were all cinematic pretenses to cash in on hyper feminine actresses who were fitting a movie maker's ideal. And this is no different in the way we live our lives day to day, with the one exception is that we're all pretty fuddy-duddy, especially during lockdown. I mean, how many people have had time to even think or care about what they're going to wear? We've all been agender in our wardrobe choices, and the whole thing to me reeks of sexism. And so I point back to the mid-1950s when New Zealand physician John Money came to, the US and was working in the US. And there was a lot of study around the Kinsey Project as well of sexuality and sexual perversion, because in the Cold War era, there was a lot of verboten topics, and sex was one of them. So I do wonder why medical practice, buttressed with the talk therapists, some of whom are, like you've mentioned, the ones who've gotten into trouble for saying that we should go ahead with talk therapy, and the other side, talk therapists, who are the ones underwriting the medical transition. They're the ones rubber stamping, this person really is gender dysphoric after 2 20-minute meetings. And it seems to me that so much of this quote unquote science around gender identity is based on mid 20th century stereotypes of gender, which is a bit redundant because all gender is a stereotype. So how is it that today medicine is curating a cultural stereotype?
Yeah, it's a fascinating question, and I agree, fully. The core of this is this concept of gender identity that is a nebulous fantasy, I call it. So it's I think perhaps so the the dyad, the couple with the uh, patient lobby, essentially, right? So is uh, and I've witnessed this. You need a small group of physicians who will uh, basically push for the positions of the lobby, and um, these physicians often, they have a personal some personal interest, or they'll likely have some gain from this as well, either in terms of status or monetary gain. But when you have, and there's a really fascinating book called it's called Great and Desperate Cures. um, See if I can find it here. It was written, Dr. Valenstein. So it's the rise and decline of psychosurgery and other radical treatments for mental illness. Really fascinating look, and he looks at a similar phenomenon to the transgender issue. And basically, it was a similar. So, for example, with lobotomy, it was a similar phenomenon. So, in the issue with transgender medicine, you have a lobby with a particular point of view that um, is at odds with biological reality and the science that currently exists on the topic. And then you have a small group of physicians who are advocating for that position, and they're the same. It's the same small group of docs who are writing all of the society guidelines and giving the lectures at the main meetings, and really advocating for the positions of this lobby. And that seems to be a really that combination can take bad ideas and push them very, very far. And I think that's what we're witnessing. So and then if you create an environment where you'll get fired if you speak up, um, there are lots of excuses that physicians who have concerns will tell themselves so that they don't speak up. They'll say, well, that's not my area of expertise. These folks who are talking about this, they seem to be experts, so I'm just going to let them figure it out. Or, oh, well, medicine goes through these cycles, and this will eventually work itself out. Meanwhile, many folks are being harmed along the way. So I think that's probably, from my best estimation, what's been the driving force.
Indeed, we're seeing with that, then the academic surge in producing a rhetoric around this. And I'm part of that. I did my PhD. Well, I started my master's in the late 80s, early 90s, and went on to do a PhD where in some of my posts where I taught, I was asked to teach queer theory. And I was happy to teach it before, as I say, it jumped the shark, in the sense of what queer theory meant in the early 90s has nothing to do with what's going on, like zilch. There was never even a reference to, in the major theorists, it was not about surgery or medical or quasi-medical or cosmetic fixing of the body. It was very much about understanding even historical literary texts. There's a famous scholar from Duke who wrote about Victorian literature and talked about romance between men through women. It was an interesting period to look at how history was being re-examined with the opening, because of AIDS largely, the opening of society towards understanding same-sex sexuality. Okay. But it went
Mm-hmm.
somewhere else. After I left that, I got into, my own work on the field in the Middle East. And I was really out of it for many years. And then it hit me one day. I was in New York. I was back in New York in 2002, and I saw all these advertisements for LGBT. And I thought, what's the T? I remember asking someone, what's the T? And they said, transgender. And I said, what the heck does that have to do with anything? Like, that's sort of like if you go to a golf convention and they've stuck in there people who play the kazoo. Like, what does that have to do with anything? We're golf players. We don't play the kazoo. And I know, silly analogies, but that's how it read to me. I didn't really understand it. And someone tried to explain it to me quite badly, because they said, well, it's just that, how you're born in, you were born this way. And I said, well, that's debatable. There's a whole bunch of literature in the 90s within the gay community of people arguing this. Michael Signorelli in New York City. Oh my God, there was a long-standing debate, Andrew Sullivan, about this. And be that as it may, the gay community never once said, you have to call me heterosexual, because that's the only way I can compare it to the trans movement. The trans movement is asking whether or not they have genuine gender dysphoria, but as a lobby, the request is, you must say my preferred pronouns, you must refer to me in this way. And as you know from the feminists advocating on social media and in very well organized groups in many countries, they are making the point of safety in terms of which sex has a propensity historically and mathematically to sexually assault or rape another. And now this has become quite politicized, still on the left of the political spectrum. And I shake my head because I'm on the left and I have no words for what I'm seeing is a very flat earth approach to science. It's really pick and choose, because you cannot, as you and I have discussed, some of the evidence behind this medicine, and I would hesitate to say that transgender medicine can be put on a paper without quote marks around the medicine word, because so much of this has been politically germinated and homegrown. It has gone through this trajectory of much of society being kind to these people, sympathetic, because they do view, many people, I think, are good-hearted and say, well, if so-and-so has a X problem, we should be sympathetic to that. Obviously, not everyone's on board with all mental health issues. There are people who hate drug addicts. They hate people who have issues with alcohol or drugs of any sort. Okay. But I think the goodwill of people historically with gender issues has been to give it a pass. That was, maybe 20 years ago. And today we're on the other end of this pendulum where if you don't call me she, I'm going to troll you for days and days on internet and call your employer and have you fired. And as you mentioned, Kenneth Zucker, his experience at CAMH in Toronto really struck me, as did the ensuing discussions following various pieces about him, including evidently Jesse Singal's piece is probably the best known. But, Kenneth Zucker was eventually cleared, and still the myth, the lie perpetuates itself within the trans community. People are not correcting the lie. And again, Ray Blanchard, similar thing happened with him in terms of his being monstered by people in the trans community who say that autogynephilia is not a thing, even though there are many trans people who admit it's a thing because they say, I'm autogynephilic. So we've got, on the one hand, hard science, which is what you labor in facts. There's no way I could go to you and say I need to have my hormones measured, and you wouldn't just do some kind of crystal ball out of the Wizard of Oz and go, hello, my pretties, and you're fine, you're ripe to have a child this minute. You would use science. On the other hand, the other section of the transgender pathologization, if I can call it that, comes from a
Mm-hmm.
therapist. And what I'm
Mm-hmm.
witnessing outside of these fields, studying this still, is that a lot has been pushed forward by people who are not, in fact, scientists, people who are talk therapists, who, if I sound cynical, I apologize, but who see a cash incentive here. People have opened up
Mm-hmm.
therapies specifically focusing on transgender teenagers or transgender men, or I've seen voice coaches offering, their whole
Mm-hmm.
studio is about offering courses to men to sound like women, or men who identify as transgender to sound like women. And
Mm-hmm.
I do raise an eyebrow to this because we're seeing a full attempt to blow identity into a leg of capitalism, which I think
Mm-hmm.
we should be ethically and morally questioning rather than
Mm-hmm.
supporting, you know?
Yeah, you can see that here in the United States. So in 2010, there were, I think, 6 gender clinics, and in 2020, there were more than 50. So whenever there's a financial incentive, even in medicine here, folks figure out a way to capitalize on that. And so that, yeah, I fully agree. And there's a danger to that. And physicians, by their training, right, we should be resistant to those temptations. It's not about money. It's about getting reducing the suffering, essentially reducing the suffering of other people, and using the scientific method to do that, and being meticulous in our data analysis, and as honest as we possibly know how to be, so that folks don't get false impressions. Because when somebody's distressed, they want relief from that distress. Understandably, we've all experienced that, and it's very easy for somebody to be misled when they're in a vulnerable state, and that's what I see happening is because of the misrepresentation of the actual data. Folks who are in distress are being misled, and promised a relief that has not proven to be there. And and it's been distressing to me to you mentioned where's the curiosity, the where's the scientific curiosity to get to the bottom of this issue, and to figure out, okay, what is the best method to help somebody who has this particular form of distress. And we have a framework in place. I mean, that's the entire point of Western medicine is you use the scientific method and uh, you know analytical tools to answer those questions, and then you sit in front of your patient who has distress and you say, okay, here's the data, and based on this data, there's more chance than not that this intervention will help you, or I cannot recommend this intervention at this time because there is no evidence that it will actually relieve your distress. And so that conversation has just been warped, because of the political climate. And I think it's understandable that the folks who are suffering from gender dysphoria would, that the lobby, you could say any lobby, if they're distressed and they're seeking relief from distress, and so not calling me by my pronouns, for example, causes distress. Well, that's part of the identity disorder, is how I see it. And then that opens up an entire uh, conversation about, okay, we've got an individual with distress, and so what is society's response to that going to be? From a medical standpoint, Um, we deal in reality, and we're supposed to, at least, and in science. And so, we should say, well, there's, I understand that you feel that you were born in the opposite sex body, but there's no evidence that that's possible. And I understand that it's, this is distressing to you. But if, we look at the data, I can't show you convincingly that socially transitioning or medically or surgically transitioning will relieve, certainly in the long term. There might be some short-term relief, and some folks do describe that. It's called the honeymoon phase after interventions, but then that wears off and leads to a desire for an additional intervention. Then there's this kind of perpetuates itself. But if you look at long-term studies, I can't in good conscience tell you that these interventions will benefit you psychologically long term. So that's the sort of conversation that should be happening between providers and patients, and that's the sort of conversation that happens in all other areas of medicine. And it's fascinating to me. A pediatrician, for example, if you ask a pediatrician about, prescribing antibiotics for, overprescription of antibiotics, oh no, the science says and the data says you shouldn't do that, and we're going to create antibiotic resistance, and most of these infections are viral, and there's no place for that. But then in the next paragraph, they'll speak about transgender medicine as if completely disregarding, and I don't yet know. I think this is mostly the fault of the medical societies, because they basically synthesize data and then they put out digestible points for busy physicians. I think that's probably the reason for this. But they'll speak of affirmation and transition as if it's settled science, in the same way that they speak about other areas of medicine that are settled. So it's been really interesting, and as a consequence of that, I do blame the medical societies to a large part, because it's their job to help out basically busy clinicians so that they can maximally help their patients, and that's just not happening. They're providing, in my opinion, false information to the general medical populace.
You're listening to Savage Minds. We hope you're enjoying the show. Please consider subscribing. We depend on listeners and readers just like you. Now, back to our show. I was turned on to an article a couple hours ago that was circulating Twitter, that came out from the Journal of the American Medical Association 2 days ago, entitled, "This Blows My Mind, Perceptions and Motivations for Uterus Transplant in Transgender Women." The authors of this are, well, there's a group, it would seem. 2 of them have bachelors, 4 of them have bachelors, researchers from the UK. What are they researching? When you look at the meat of this article, it's basically a survey asked of transgender identified males if they would like to have a uterine transplant. This strikes me as, one, not at all scientific. If I run around asking people, would you like to go on holiday this very second and we'll pay for it? I mean, who wouldn't say yes to that, and cancel COVID? Yeah, all of us would say yes to that. We're asking, these kinds of studies, quote unquote studies, and I've seen them also, a lot of op-ed pieces in science that get circulated on Twitter sphere as this study. And then you're like, you have to tell the person that's not a study. Right. That's an op-ed. It's like 200 words. They're being circulated as proof of something. And I am a bit worried about, when I saw this, I thought, this is quite Frankensteinian. Women's bodies are being treated And I focus on women here because we're not seeing the same kind of reification of men's bodies by women who identify as transgender, but we're seeing it in terms of cancer societies, doctors, surgeries, etc. It's cervix havers, people with cervix, people who menstruate, pregnant people. People with breasts, and I'm like, I mean, I started a few years ago, I started calling men, LOL, front noodlers. Cause I'm like, okay, let's just all make up names for everyone else because this is deeply offensive. But I do feel like women have become this shop, like a mechanic's shop of, take out the old carburetor and let's put this new one in. And how in earth is the medical profession? I mean, this is the Journal of the American Medical Association running a basic survey as fake science. I mean, this is absolute hokum.
Yeah. There was an article recently in the New England Journal of Medicine, kind of considered the pinnacle of medical journals. And it was an opinion piece, but it was featured front and center, and the journal tweeted out to bring attention to it. And basically the argument was that sex should not be recorded on birth certificates any further. And this argument was made by a couple of the authors were physicians. And that example and the examples you've given, and I've heard a lot of resistance coming out of midwife groups and doulas, basically groups essentially mandating that they change their language in the ways you've described, which is understandably shocking and distressing. I don't know if this has the potential to spill over into other areas of medicine, but the danger always is if there's this sort of dissociation from reality occurring in one area of medicine, could it bleed over into other areas? And that's, and then essentially you start to challenge the entire foundation of Western medicine, which is, using the scientific method and biological reality to make decisions. So, I don't suspect that will be thrown out the door anytime soon, but it certainly makes me concerned to see this in one area of medicine. I think many of us thought, well, this will kind of run its course, and eventually enough folks will say, you know what, this doesn't make any sense. We're not going to do this. We're not going to go along with it. But the opposite has happened. It's showing up in JAMA. It's showing up in the New England Journal of Medicine. It's not just in kind of throwaway journals anymore. It's been mainstreamed, and it's being institutionalized and also legalized. It's in the United States. There's a big push to put gender identity into protected class. So it's gone in a short period of time from a niche and a fringe to mainstream, and it's been it's been shocking actually to see. I figured in the last 3 years that many more folks would start to speak out, and my assumption had been that other physicians in the field just did not have the foundation, the background, or the familiarity with the literature to feel comfortable speaking out. And so that's one of the things that I've been working at, is trying to to help physicians get comfortable with the literature to see in this area, to see really how weak it is, so that they'll have some confidence to to question it, and we'll see if that happens.
Well, let's hope. I mean, I also find the lack of understanding about how these procedures came into being part of the most shocking part to me, in the sense of going back to, money. He got his career start in this field by quote unquote fixing the baby David Reimer, who, because of a botched circumcision, was left without a penis. And it was money who said, well, we need to turn this child into a girl. And I'm horrified just thinking of that, honestly, because in the 50s and 60s, medical ethics were at the level of, well, let's electroshock these thoughts away, with little to no research at all on these methods. And we know even, Francis Farmer, what results were for many of these people, to include a lifetime of depression and suicide. Well, this surgery of baby Reimer ended up quite badly for him. And it's very shocking to me that people are very unaware about what happens when we invoke lifelong changes on the body of even adults, but especially children. And how this has taken hold, the kind of harassment that Lisa Littman went through for writing a well-founded and well-researched study on, ROGD, rapid onset gender dysphoria. But no, that has her also likened to, the, what is it? Ad hominem ad Hitlerium, everyone's a Nazi who disagrees with this lobby, when clearly people are from all political persuasions, because I think what we all have in common, regardless of our political persuasions, is that we value open debate and we value science. And I'm rather shocked by how this lobby is purporting to have science where its ethos historically was based in something that was a tragic accident of a baby who was then consciously mutilated by a physician having a test go at a child who later, I mean, because this child also had a twin sibling, and, suicide was the end result. So I really have to wonder why mass media, you go to CNN, and these days, especially since yesterday, because of Biden trashing basically Title IX, with this new legislation that will erase some of the protections that Trump had put into place for women and girls sports, aside from women and girls bodily autonomy and the right for them to declare who can and who cannot touch their body, in the sense of, do I have the right to tell a police officer, no, you can't because you're not female, And these are now questions that are coming full center 2 days after a new U.S. president was sworn in. I myself am deeply shocked by some of the people in the Twitter sphere who I agree with in their arguments about gender identity being really troubling for women and children, but they were absolutely floored by Biden's, as they saw it, a last minute shift. I'm like, no, this is not a surprise. We all expected this because he's been saying this for a year. He said he was going to do this in the first 10 days of office. He did it on his first or second day of office. So we're seeing now where this is becoming so hyper politicized that I worry that in the States, there's little way backwards out of this.
Yeah. So, it's a great question. I mean, to me, it shows the, the power of an effective lobby. Lobbying is highly effective, and especially when it's coupled with a small group of advocates who are physicians. And it is it's a relatively small group, like I said, who are pushing this on multiple fronts within the medical societies, and then they're also the go-to folks out in public for the media, and so they've been highly effective at shutting down discussion, debate. Not allowed to question, not allowed to be curious, not allowed to raise your hand. And I think you're right. I think if so, it was an executive order, but if legislation does get passed, uh, with the gender identity in it, yeah, it's very hard to undo. And so I haven't spent a lot of time on the legal side of things. I've had my hands full with with just the medical side of it, but certainly if that comes into law, um, it validates essentially this concept that is unscientific and has no basis, and then it becomes much more difficult to explain to people problems with it. Well, it's part of law. It's endorsed by medical societies. It's on the news when I see it. When I watch the news, I see this. So it's a very it might be quite some time. If I look at what happened with the opiate epidemic, there was a big push, right? So pain was the fifth vital sign, and if you were a physician and your patient's pain was not well controlled, you were a bad doctor. And you needed to ask about pain at every visit and ensure that it was controlled. And in theory, I certainly don't think patients should be in pain. And in practice, we try to minimize pain the most that we can, of course. And there are specialists who pain management specialists, et cetera. But an effective lobby basically convinced almost the entirety of the medical profession that a certain class of opiate was non-addictive and could be prescribed at will. And then there was pressure from the medical societies, and then also patient satisfaction surveys within hospitals. Well, Dr. So-and-so gets a poor rating in terms of pain control. Really shifted practice overnight. And it almost seems to me that it wasn't until there was massive destruction from the opiate epidemic that people started to take a look and say, oh, maybe we've made a mistake. And so I wonder if the same thing is going to occur here, where it's going to take significant harm before people start to realize something is occurring that should not be occurring. And that's unfortunate. Obviously, that shouldn't be the way that these things evolve. But if I look honestly at how the opiate crisis ended, it was litigation and obvious harm to patients that was visible to the general population and to physicians. And then a study came out showing, oh, look, as a matter of fact, long-term opiates are no more effective than other methods of pain control. And so then when it was culturally acceptable due to the harm being done to speak up against the use of opiates for pain management when they're not needed, long-term especially, when it was culturally acceptable, then the physicians said, had the confidence to say to their patients, oh, there's this study showing that these drugs don't actually work long-term. And so I'm not going to prescribe you long-term opiates. And then, it did shift rather quickly, but it was, back. It was kind of a whiplash in a short period of time, but it took a tremendous amount of destruction, and it's still playing itself out before it got enough attention where things started to change.
I've thought a lot about the generations of how medical practice has been performed since. I'm thinking of when I was living in Brooklyn in the 1990s. Every other parent I spoke to had a child who was diagnosed as ADHD. They were on Ritalin. Oh, I think more than 50% of New York City kids were on Ritalin in the 90s.
Yeah.
And I do wonder, from an anthropological perspective, if not, this is a continuation of the ethos of we pay attention to each other, our parents who are working hyper extensive hours. We don't have quality time for kids, but let's diagnose them with something. That's the way we show love. And that we've almost replaced a lack of a real life community, as they say on the internet, IRL, with all of these other fixings. And I do wonder if this is not continuing towards gender dysphoria. It's just a new way of filling that cultural void, because we're not really having much of a culture when individuals are swapping stories. Teenagers are swapping stories about how they're going to be taking this dose of this hormone, or how they're thinking about getting top surgery. And as you know, a good deal now with the, thanks to Littman's great work on this subject, we are seeing a 4,000% increase of referrals of teens in the UK alone. And a good percentage of the majority are female, and a lot of those females are autistic. So we're seeing one problem, dominoed up on another.
Yeah.
And it's really striking to me how there seems to be no ombudsman involved in looking at this from a meta perspective and saying, what's going on here? Because
that's a great point.
Our culture is very, and I don't just mean America or Canada, but Western culture is very much about the customer as king. And doctors particularly, you are all in a very particular position. Should a patient, especially now with Biden's attempt to wokeness, should a patient feel that you're saying no because you're just a bigot? What will happen to the careers of doctors, similar to Zucker as a therapist, who say, no, I don't think this is the best road, and I'm not signing off on this. We've married capitalism to the will of the self, to a cultural abyss where there's no more meeting, no more culture.
Yeah. So most physicians are paid by hospitals. They're employed by hospitals now, at least in the U.S. And part of many physicians' pay structure now is patient satisfaction. So it's the compensation now for many docs, because obviously the hospitals, right, they want happy patients, because happy patients come back to the hospital, and so they've basically integrated that into the pay structure for physicians. So what I've witnessed is two things happening. One is that physicians are really, and obviously, right, you want your doctor to have good bedside manner and to be approachable and friendly and all those things. That's just good decent behavior. But I've seen physicians very reluctant to say no to patients when they ask for things that might not have evidence to support them. And also, I'm seeing physicians reluctant to take on patients who may be more difficult to take care of for a variety of reasons, who may be more likely to complain. So it really has, I think, it doesn't take much to subtly shift that patient-physician interaction, and it really should, in an ideal world, that interaction should be, based on, the foundations of that should be ethics, honesty, and applying evidence-based medicine to make recommendations. And then when these other factors come into the room, it can very easily alter that relationship in unfavorable ways. And then, I think you brought up a great point about this new phenomenon, what's been termed rapid onset gender dysphoria. So essentially, this framework of transgenderism has existed, as you mentioned, going back to the 1950s. But then, right, all of a sudden, so and it probably had to do with the introduction of puberty blockers in the early, so 2010 or so in the United States. So basically, the puberty blockers, in my opinion, they once word got out that that distressing puberty could be halted, if and for young women in particular, with autism or struggling with same-sex attraction, or history of trauma, other psychological diagnoses, start to go through puberty, which is a momentous change physically, psychologically, socially. So okay, now I'm a distressed individual, and I have the opportunity going through this distressing event, which is at baseline distressing, and now more distressing for whether it be autism or the things I mentioned. That essentially, it appears, and there needs to be more study on this, appears to have triggered a social contagion. And that's certainly what many of us have witnessed in terms of, we talked about the peer group contagion, where, okay, I can stop my puberty, or I can take testosterone to alter how I look and how I feel. And testosterone is, it's psychoactive. It gives confidence, etc. And okay, here's a solution to this distress that I'm feeling. And so it's triggered this massive wave, as you mentioned, of predominantly adolescent girls, females, declaring transgender identification, and this group looks nothing like the traditional childhood onset gender dysphoria that was long-standing and traditionally males. So there's been a complete shift in the demographic, and I attribute, it's a perfect storm essentially of there's a powerful lobby with a small group of dedicated and ambitious physicians supporting that lobby. And now the introduction of a medical intervention that can halt a distressing event for some adolescents, namely puberty.
And also the media is another layer on this, I've noticed, because as you saw, maybe if you saw the Jazz Jennings reality TV show, not just there, everywhere you go where they're interviewing parents are feeling awfully proud of themselves and getting a lot of backslaps for being supportive of their transgender child and so brave. You've seen the words being used.
Yes. Mm-hmm.
And I do find it completely an inversion of honesty and of bravery. I'm sorry to say this, but I think that these are overused terms, for one. I mean, really, what's brave? I think we use these terms very in a slippery way. And I don't think there really are more than cliches in the sense of, why are we validating what should be private medical decisions? First of all, why has this become even a public reality TV show? Something that really strikes me as ill-founded about the Jazz Jennings show is that people were witnessing a young man's life being ripped from him in a very grotesque, almost carnival circus-like way. What will happen to him in 20 years if, and statistically when, he is very fraught with various mental health issues, to include the fact that he wakes up and realizes at the age of 16 he was a circus freak. I'm sorry to put it like this, but we know the history of freakery. We've seen, there's various movies about what happened when the French went to South Africa and brought this Hottentot, as they called her, back and caged her for years until she died, a very tragic death. We know what happens to these people. This is just a postmodern freak show, in my view. And I think it's a very cruel one, because these people who genuinely have gender dysphoria or who genuinely are caught up in the social contagion are not being addressed by adults in the room. You know what I mean?
Yeah. Yeah, no, yeah, that, that show certainly, I think, those and shows like that, contribute to, uh, you know, the social contagion aspect of this. It's interesting. There was a documentary in Sweden called The Trans Train, which basically took the opposite approach and highlighted a young woman. I don't know if you saw it, who, uh, yeah, who, right, she was, it was the wrong decision for her, and highlighted the impact that had on her, and the number of referrals in Sweden after that documentary, and obviously it's hard to know if that was a direct correlation, but the number of referrals seemed to be dropping off. Yeah, that show, that Jazz Jennings show, it showed a lot of, highlighted a lot of the issues. I think um, many of the parents are um, essentially, threatened with this uh, risk of suicide. It gets held over their head. So, um, because pretty much anywhere, if you bring an adolescent to a gender clinic, it's going to be an affirmation only experience, and so the clinicians will hold this threat of, well, your child's going to kill themselves if you don't support their transition, and et cetera, et cetera. And there's just simply no evidence to show that. We do know that kids who are transgender identified in adolescence, they do have higher risk of suicide. It's still low overall, but it is higher than the general population, and correlates with the number of underlying psychiatric diagnoses. So I think, some of the parents maybe many of the parents basically feel that they have no options because of the cultural environment, and then the direct message that the doctors will give them when they consult with them is, "Oh no, you must support this transition. This is settled science, and your kid will kill themselves if you don't." And also, so I think that's how a lot of parents find themselves in this situation, with really no good place to find information. And then also, Jazz, he had his puberty blocked at a very young age. And as a consequence, when he had the genital surgeries, he had complications, very little tissue because it stunts genital development. So there was not tissue available for the operations that he had. And um, that's also a reality that is not, I don't think, adequately discussed with families when they present with a young person who's distressed. So it's a bad situation all around. Yes.
Yes, and also the fact that back to the 1950s, many men are clued into this too, by the way, but I'm speaking as a woman right now. When I
Mm.
hear this, feeling like a woman, I've given birth to 3 children, I really don't know what they're talking about, in the sense of,
Mhm.
what the heck? It's not like that commercial from the 1970s in the States. Anjali, there's this woman that says, "I can bring home the bacon fried up in the pan," and she's like decked out in a really ridiculous evening gown, and that no one would wear to cook dinner, but that's what she's doing. And I think of that a lot when I hear them say, "But I feel like a woman inside." And I'm like, but just be yourself. Be one of the million rock groups of the 1980s that the men were wearing makeup. Duran Duran, all of the
Yeah.
men were wearing makeup,
Yeah.
not just Boy George. I mean,
Yeah.
I dare anyone to find me a rock star from the 1980s, male, who was not wearing makeup and funny hair. And,
Yeah.
so I keep thinking, well, what is this impetus towards estrogen or hormones, and now this survey by JAMA about transplanted uteri. And why not just tell the gender dysphoric subject, if you really want to feel like a woman, I'll give you a pay cut. You know, I mean, I'm being tongue in cheek here, but it's always about to me, the most far-fetched things about being a woman, because being a woman is about many things, and it's less and less about discrimination in many societies, or it's differently about, like, we're facing this kind of weird fetishization from the transgender narrative, which I never thought I would have to answer to in my life, because I felt very free as a woman until this narrative jumped up out of media pages everywhere. And I have to, what, you have a pronoun? Because I don't have a pronoun. Look at my name. I get emails 50 times a day saying Mr. Vigo. I'm fine with that. I don't care. I'm not going to sue anyone. How is it that medicine has been the gateway, medicine/law has been this gateway to giving these people some kind of certificate of authenticity, when all of us deal with struggles in life? All of us have these struggles with even our own authenticity. Isn't that what life's about?
Yeah. No, it's a great point. I think it gets back to gets back to your earlier point. Stereotypes and behavior and preferences are not don't define one's sex, and I don't. I think that where that went off the rails, I think the lobbying effort, essentially something that was almost obvious and taken for granted, this intense lobbying effort has basically erased that, and so it's almost as if we have to bring people back up to speed on this. Okay, no, personality and preferences, there's a wide variation within each sex, there's overlap between the sexes, and your personality traits and your preferences are not your sex. And the more that I am working in this field and reading and learning, I think there's been a very effective lobby to argue the opposite, right? Which is, no, your personality and preferences are your sex. Your gender is your sex, and that's just it just flies in the face of common sense and actual scientific literature. So that needs to be corrected. And when a bad idea permeates the culture, in a sense, almost like a social contagion itself, this concept of gender identity, how quickly it permeated throughout the entire culture. It takes a long time and a lot of effort to undo that. And so it's definitely going to be a challenge. Yeah, I'm not naive about that. I think it's going to be a while before basically this bad idea is rolled back.
Certainly, it's going to be a struggle for the next 4 years, given that Biden has now appointed Rachel Levine, a transgender identified male, as the assistant health secretary, who has worked on the transition of children, from what I've read. So this a pediatrician who enables this at the height of this discussion in the UK, which has sort of blown the circuits worldwide open for practitioners, therapists to speak out. Before, it was not that way. Even 2 years ago, you couldn't say very much. And we've got someone who doesn't know the difference between sex and gender as number 2 in one of the highest offices of health in the United States.
Yes. Yeah, I think when this is all a consequence of basically the mainstreaming of an idea that is, this gender identity idea that came from the lobby, and has worked very hard to shift public opinion away from scientific reality, and they've been highly effective. And so, the situation that we're facing, and there's obviously there's a cost to that. There's a cost, to the young adolescents who get caught up in this idea that by halting their puberty or cross-sex hormones, that this will relieve their distress long term. There's a social cost that you've discussed, and so when I really fault heavily, if I take a look at the big picture, the medical societies, and I think similar to how individuals in society, they want to be accommodating and they don't want to hurt feelings, and all based on decency, basically allowed the perpetuation of unscientific ideas, and didn't question with enough rigor. The medical societies did not question with enough rigor the science behind these interventions, and as a consequence, they took off and permeated the rest of the culture. And I might be a little, biased against the medical societies, because that's, my life, and my frame of reference essentially is that I expect other physicians, and I expect our medical societies to hold the line, even when under significant pressure, to hold that line and to say, no, there's no scientific evidence to support these interventions at this time. They should be considered experimental, and experimental therapies belong in controlled trials, not out in the general population. And when interventions, such as puberty blockers that are experimental, end up out in the general population, and they don't have evidence to support their effectiveness, a lot of harm can be done. And I think that's what we're seeing. So it's really, I've been very disappointed personally, and have felt very let down by academia and the medical societies. I think it's really a stunning failure on their part, and we're seeing the consequences of that.